Hello, hello, and welcome to this lecture on meningitis and encephalitis. We will spend the bulk of our time talking about meningitis. So let's get started. As always, we will be using next-gen thinking to talk ourselves through the diagnostics and care of the patient experiencing these inflammatory brain disorders. Okay, so meningitis is basically acute inflammation of the meninges tissue that surround the brain and the spinal cord. And if we remember from some of our pathophysiology, increased inflammation of the brain equals increased cerebrospinal fluid production, which then can give us signs and symptoms of increased intracranial pressure. So we'll start our conversation with our recognizing and analyzing cues. Okay, so as we were saying before that basically meningitis can be bacterial or it can be viral. Bacterial definitely has the worst prognosis. In fact, mortality rate of up to 100% if untreated bacterial meningitis. Bacterial strep is usually caused by strep pneumoniae, Neisseria meningitis, and of course Haemophilus influenza can also be a cause of meningitis. There are some prime times, if you will. So prime time for meningitis is going to be fall, winter, and early spring. So as part of our understanding of our background, so fall, winter, and early spring are important to note because it's more likely that this is what you're dealing with when you see patients with these signs and symptoms at that time. So this is when people are inside the most, and your typical person would be somebody living in close proximity. They would be at higher risk. So think about our college students, people in senior centers, anybody in conditions where they would be close together. All right, so signs and symptoms that we would see that would be classic for meningitis. Again, this is just meningitis. Nuchal rigidity. So that's the stiff neck. Kernig sign. And also fever and headache. So those are all classic signs, especially that nuchal rigidity and the headache. Also, you could have some cranial nerve dysfunction. So just based on the inflammation. So you might see some of those problems. Photophobia, where the lights bother them a lot. You might have a change in level of consciousness, including things like disorientation and anxiety. They may have altered mental status, so that's what that would be encompassing, right? Disorientation. Some of the other problems that could happen would be nausea and vomiting, always potential. Sorry, I didn't quite spell that just as nicely as I should have, huh? So we'll just throw it back down here. So nausea, we'll put it up on here. In the case of meningococcus meningitis, you have something called the tumbler test. And basically, it's an old way of saying it. is that they would put a cup on a rash, and if the rash did not fade, then that was usually meningococcus meningitis. So basically it is a non-blanchable rash for meningococcus. Okay, so you could have all these signs and symptoms, whether or not it was bacterial or viral, except for, again, this one was often with the meningococcal meningitis. So just as a question for you guys, what do you consider are some cranial nerve dysfunction? What are some signs and symptoms of that? Well, hopefully you're starting to think of cranial nerves 1 through 12 and what they do. So you might have some eye issues, including blindness, double vision, deafness, vertigo. All depends on which cranial nerve is being affected. Now, if we were to briefly just discuss encephalitis and the signs and symptoms, that would also be crossing over towards encephalitis. Basically, pretty non-specific. So encephalitis, let me just put this over here. It's pretty non-specific onset. Otherwise, it's headache, nausea, and vomiting, right? So for those, though, remember encephalitis is caused by mosquitoes and ticks, and so these are mostly viral issues. However, there is usually something in the patient's history that would point us in that direction, right? Whether they were outside or some other risk factors, right? Because this is where we would come into contact with mosquitoes and ticks. All right, so the next thing we're going to do is continue on into the relevant diagnostics. Okay, so early and accurate diagnosis of meningitis is key so that we can treat the patient. So I would like to have you guys note very well here, again, this is meningitis, so note well, note bene, that treatment starts before the diagnosis is confirmed. And that is because we cannot waste time. If we suspect bacterial meningitis, we will treat it just as soon as we get the cultures. And what kind of cultures are we looking at? A nasopharyngeal swab, so cultures, let's look at that. Or it might be a nasopharyngeal swab, so just like people who were getting tested for COVID, that sort of swab. They might also have blood cultures taken. Lumbar puncture, which we'll talk about in a moment too, so we'll leave ourselves some space over here to discuss that. We might do some labs, so we want to check a CBC with differential, perhaps even a CT scan to look at the brain. Some of the other things that might be done might be an EEG, especially in the case of seizures, which are a possibility for meningitis. All right, so what would the cerebral spinal fluid look like? So first, let's look at what the normal cerebral spinal fluid is. Okay, so normal would be that the pressure would be less than 20, that the WBC would be less than 5, and that's 5 cells, that the protein is between 15 and 45, and that the glucose is between 50 and 77. All right, so what do we have going on here? Well, a lot of it depends on whether or not we have bacterial or viral meningitis. Remember, bacterial is the absolute worst of the two. So I'm going to just kind of, and this is in your textbook. If you're on the 11th edition, it's on page 1324. But what would we see? So we would see increased pressures, and much more increased if it's bacterial versus if it's viral. Increased WBCs. For bacterial, upwards of 1,000, where viral is usually between 25 and 500. Protein for bacterial, upwards of 500. And viral would be less than that generally. And for bacterial, for glucose, it's actually down. And significantly so, so between 5 and 40, where viral is normal or low, but it wouldn't be under 40. And when you look at the color of the cerebrospinal fluid, bacterial is considered to be turbid and cloudy, versus viral, which can be clear or cloudy, but the word turbid is not used. Now, to compare this to encephalitis, which we still use some of the same diagnostics, encephalitis. I do not know why I just did that. So encephalitis, we would have just a normal to slight increase in the pressure, a high white count of about 500, slight increase in the protein, glucose is normal, and it's clear. So the lumbar puncture is more benign. But again, think about why. It's swelling of the brain itself. All right. So we're going to be heading on over to prioritizing hypothesis. And so let's get over there. And as you can see, I kind of use some of my information over there. So what are our hypotheses? Well, of course, we're concerned about shock. And there's specifically when we have meningitis that goes unchecked, it can lead to certain conditions, including DIC, shock, vascular collapse. We worry about increased intracranial pressure and seizures, which is a safety concern. So those, I think, would be my main priorities. All right, so I'll meet you over in the next section, which is taking action. And just before we move on, I did want to mention that we do the lumbar puncture for bacterial meningitis only after the CT. And again, we're looking for protein, white blood cells, and glucose. So, all right, generating solutions and take action. This is a medical emergency. Bacterial is a medical emergency. Again, these folks are generally very ill appearing with a high fever, severe headache. They may be having seizures. And for us, meningitis is respiratory isolation until proven otherwise. And bacterial meningitis is such a concern that it is absolutely reportable. And we have to treat people that the person with bacterial meningitis has come in contact with. All right, so what are we going to do? After we get the cultures and we begin treatment, we are using broad spectrum antibiotics. So we're bringing in the big guns for these guys until we can narrow it down by culture track. We're going to manage the patient's headache. So let's just put some things down here so we're brainstorming together. Antibiotics, managing the headache. Because again, they're going to have a headache. They are going to have high fever. So our nursing assessment is going to really be looking at their vital signs, their neurostatus, intake and output, their lung sounds. Remember, it's a respiratory spread. Uh, so lung assessment and their skin, potentially that rash. The patient does need rest, and we want to minimize a lot of activity around the patient because remember the need for rest and to decrease the brain activity because the brain is going to be working pretty hard now. And as we discussed in our previous lectures and in class, that if a brain that is working hard is going to have increased issues with pressure. So we want to kind of settle everything down. So position them for comfort, dark room. We don't want to cluster care for our patients who are acutely ill with these sorts of disorders because it becomes more of an issue for the patient. It actually causes more stimulation. All right, so dim the lights. We can put cool cloth over the eyes. Whoops, where did everything go, huh? Guess it's just moving on me. Sorry for that little wiggle. There was some sort of an issue going on with the computer there for a minute. So we want to decrease the brain stimulation. We want a dark room. We might use cool compresses. If a person is confused and agitated, it would behoove us potentially to let familiar people at the bedside. So let's talk about how could we put that? A sitter, familiar people. We need to consider delirium management. So that's why familiar people would be helpful. What else can we do? What do you think? What are some things? How about seizure precautions? And what those look like. In fact, we may even have them on medications to treat that. We need to treat their fever. We need to treat it very aggressively. We don't want them shivering. Proper nutrition is important. We have to manage their fluid status because there's a lot of fluid loss with this, right? Because of their basically hypermetabolic rate. So when we do our fluid management, what we do is we give them 800 mLs a day for respiratory loss and then 100 mLs for every degree above 100.4. All right, what else can we do? Remember, it's respiratory isolation, which means the nurse needs proper PPE. How about taking care of a patient after a lumbar puncture? Do you guys remember how to do that? All right, so what do? Let's just talk about it. We have the head of bed at 20 degrees or less. We make sure we give them plenty of fluids. So we don't want to have some problems with loss of fluids after the lumbar puncture. And always be on the lookout for our good neuro assessment. Remember, people don't generally need to be under anesthesia or anything for a lumbar puncture, but they do have to maintain their body positioning. There are a lot of residual effects to a person who has bacterial meningitis, it takes several weeks or longer of recovery. So that's a good teaching for our patients. So it is I don't know what happened there. Let me just go back to that. So it is a long recovery, very long recovery. All right. So I think that's good. For viral, because we were talking a lot about bacterial, for viral, it's generally supportive and more self-limiting for the most part. And encephalitis, it's the same thing, largely supportive. And for all of these disorders, we want to make sure we are monitoring for signs and symptoms of increased ICP. Okay, so we're going to move on down to the medications that are must-knows. Okay, so first class of medications to know would be the antibiotics. Often we are using ampicillin, penicillin, the cephalosporins, dexamethasone. Dexamethasone can be very helpful as it guards against some of the increased inflammation. Another medication we might use is acyclovir, but only for encephalitis, viral encephalitis caused by that virus. Okay, so some of the other meds, what might we need to give them? Analgesics, right? Because of the severe headache. So preferred would be something like codeine. Codeine along with Tylenol. APAP is the old-fashioned way of saying Tylenol. So if you see me write that, it's just so much faster than writing acetaminophen. We might also treat their fever with Tylenol and aspirin. Anti-seizure medications. Phenytoin is an exemplar medication, so phenytoin. And what else? Levetiracetam or Keppra. So we would give those anti-seizure medications. If we have increased intracranial pressure, it's potential that mannitol might be used, which we discussed under some of our previous lectures. Okay, so again, this is just a very quick down and dirty kind of overview, but I do want to add one more thing. And it's not just in medications, we'll put it in medications, taking action, things like that, is if we can prevent these things, it's so much better. So how can we prevent bacterial meningitis? What can we give them? Vaccines. We do have several vaccines available. So kids who are going to high school or college, they are the ones to get that. And the other is for encephalitis, especially things caused by mosquitoes like West Nile or tick-borne illnesses, then we would definitely want to use repellents, right? Use insect repellents when we're outside. Okay. All right, you guys. So this has been 24 minutes of your life that you can't get back, but hopefully you learned something out of it. All right, so once again, this is Mrs. White, and if you like this content that I'm putting up here, give me a like and a follow, and other than that, I will see you around. Thank you so much.